So as I said, today is a very special day. It's one of our named lectures, the JANSSEN lecture, and here to tell you more about it is Dr. Yael DeVere, who's the Vice Chair of Child and Adolescent Psychiatry.
Thank you, Tony. So this Grand Rounds lecture celebrates the legacy of Deborah JANSSEN's RN. Deb was a former Adolescent Continuing Care Unit Program Director and a nurse who believed in compassionate, inclusive, and multidisciplinary approach to mental health care. I especially want to welcome her family members who are joining us in person today for this lecture. So Deb was an employee of UMass, both medical center and the medical school from 82 to 97. She started as a staff nurse on the adult mental health unit, which is now 8 East, and then became a nurse manager on the adolescent units in 88. In 91, she joined the faculty of Anna Maria College, and she taught group therapy and process in the graduate nursing department. In 93, she became the program director for the adolescent units, and in 95, also helped open up the transitions intensive residential treatment program. In May 1997, she received the Department of Mental Health Distinguished Service Award in recognition of her exemplary leadership and creativity in establishing and directing treatment programs for adolescents. I know that we have DMH colleagues joining us on Zoom today, and by email, some of them have shared warm words about Deb's legacy. This will be our final JANSSEN's lecture as a result of the transition of the adolescent units to Worcester Recovery Center and Hospital and the DMH administration. Our Department of Psychiatry at UMass, Chan, will transition this annual lecture to a new format. So May is Children's Mental Health Month, and we will continue to have a lecture dedicated to children's mental health awareness in the month of May in the years to come. So thank you for joining us today for this important lecture. Now, it is really my pleasure to introduce today's speaker, Dr. Wynne Morgan, our own faculty member, who is going to talk to us about deprescribing in children and adolescents. I do want to also say that typically for this annual lecture, we recognize employees of the adolescent units who exemplify, Deb's mission of taking care of kids and treating everybody as equals. And this year, I really want to recognize our 3 faculty members, our 3 psychiatrists, Dr. John Ewok, Dr. Colin Whitworth, and Dr. Boris Lorberg, who 2 of them are here today. The other one, I think, is on Zoom, joining this lecture for outstanding work throughout the past few years that have been quite challenging in treating children and adolescents, and for really leading the program throughout this transition. So back to Dr. Morgan here. So Dr. Morgan is an assistant professor for psychiatry and pediatrics at UMass Chan, and a graduate of our medical school and our residency and fellowship training programs. She is the co-program director for FACES MCPAP pilot, previously known as FACES Safe and Sound, which is a clinic that takes care of children in foster care and addresses their mental health needs. She has worked tirelessly in the medical center to really advocate for trauma-informed care in pediatrics. She is also the consultant child and adolescent psychiatrist for the Department of Children and Families, so DCF, where she has established the antipsychotic medication monitoring program. She also is a peer-to-peer reviewer and is part of the quality assurance committee, doing a lot of important work. On the national level, Dr. Morgan is the co-chair of the American Academy of Child and Adolescent Psychiatry Adoption and Foster Care Committee since 2018, which means that she has a lot of impact in the country and pushing for some of these important initiatives. She is also a contributor to the clinical update that is entitled Ensuring Appropriate Prescribing of Psychotropic Medication reduction and discontinuation, which has been submitted to ACAP and is under review currently, and a guest associate editor for Frontiers in a topic about the impact of exposure to maltreatment. I could go on, but I think I'm just going to let you give your talk now. Thank you. I look forward to it.
Great. Okay. Thank you, Yael, for that warm welcome. And I'm very excited to talk today about a topic that's near and dear to me, deprescribing. This has been a national effort at ACAP that I've been a part of as my role on the adoption and foster care, really trying to incorporate deprescribing practices into child and adolescent psychiatry. So I'm really excited to talk about our work today. I have no disclosures or conflicts of interest. I am going to be discussing off-label use of medications, the entire class of antipsychotic medication, particularly risperidone, and then mirtazapine and guanfacine. The learning objectives for today we're going to talk about the risk factors associated with polypharmacy and pediatric psychopharmacology. I'm going to discuss and define what is deprescribing and how we can apply it to the field of child and adolescent psychiatry, and then walk through best practice guidelines that I've helped develop within ACAP. So what is deprescribing? Deprescribing definition comes from the work of Gupta and Cahill from their 2016 paper. And it's a structured approach to the discontinuation of medication with the goal of parsimonious use for medication. That is designed to provide the minimum effective dose and number of medications. So we're not saying don't use any psychotropic medications at all. It's making sure that you're using the lowest number and the lowest dose. Deprescribing is a response to polypharmacy. It's a way that we can prevent unneeded prescriptions for psychotropic medications, a way to prevent polypharmacy, and it's a way to address polypharmacy when we see polypharmacy in practice. So what is polypharmacy? So polypharmacy, the opposite of deprescribing, is when you're using two or more psychotropic medications in the same patient. So there's intra-class polypharmacy, which is within the same class, so using two antipsychotic medications. Inter-class is in two different classes, so using a stimulant or alpha agonists together. What are the risk factors for polypharmacy? So there's been a number of studies that have highlighted the risk factors for children in the child welfare system being overprescribed psychotropic medications. There's studies that have shown that youth in the child welfare system are 5 times more likely to be on polypharmacy when looking at their same age Medicaid peers. Low socioeconomic status also is a risk factor for polypharmacy. Youth with disability, being in a congregate care placement is a risk factor for polypharmacy. And then having the pediatric diagnosis of bipolar disorder is also a risk factor for polypharmacy. So why are we concerned about polypharmacy? Julie Zito and her team in Maryland has really done a lot of researching, highlighting the concerns with the overuse of psychotropic medication, and she's pointed out over and over again just some of the concerns for polypharmacy and pediatric mental health. There's really limited research that we have in our field of child and adolescent psychiatry around using two psychotropic medications together. The exception for this is the use of alpha agonist and stimulant medication for ADHD. Other than that, there's really not a good evidence base. There's also concerns for safety. So as you're adding medications, you're increasing the risk for drug-drug interactions. And these polypharm regimens really require close monitoring, especially in pediatrics. So deprescribing has been around in the adult literature and has shown some significant benefits. So deprescribing in the adult literature has been shown to optimize safety, reduce the risk for adverse drug reactions, improve adherence, and reduce costs. Deprescribing is really a part of good prescribing. So it provides a structured approach to reassessing the medications over time. And we know that mental health changes over time, which means that the medications that we're prescribing should also change. The treatment type, the age of the patient might vary, which medications we use, where they are in development, course of disease, the health, and then of course the preferences of the patients and families. So deprescribing is a tool that we can incorporate into our practice to potentially avoid inappropriate use of psychotropic medications. That being said, what is in the adult literature for deprescribing can't just be kind of applied to pediatrics. Pediatric patients are different than our adult psychiatric patients. The risk-benefit ratio is different. So if you're starting a 3-year-old on an antipsychotic, that's a lot different than starting a 30-year-old on an antipsychotic. What is that medication doing to the developing brain? How long does that child need to be on the medication? The longer that they're exposed to that medication increases the risk for them to develop a side effect or adverse effect. As children develop, there can also be different kind of changes that occur within their development. Their cognitive abilities changes. So an outburst in a 5-year-old is different maybe than an outburst in a 15-year-old, and you might address that differently. The impact of puberty also impacts the mental health and our approach to psychotropic treatment. There has been work in deprescribing in the last decade. And it's actually within our residential settings is where the biggest kind of, or where the first body of literature comes from. And these are working with often vulnerable patients that have child welfare involvement, but also inpatient hospital and then juvenile justice settings are also settings that have some deprescribing literature. In these settings, are opportunities to apply deprescribing because they're structured and contained and you're able to kind of hold the patients in those settings. Outpatient deprescribing, there's not as much of a literature base there yet. So these are settings also where kids are at risk for polypharmacy, at risk for higher polypharmacy rates. Having to do in part with years of out-of-home treatment when you're thinking about the residential population or repeated hospitalizations when you're thinking about the youth that are in residential populations. So one of the first articles that comes out from the deprescribing in the residential setting is Connor and McLaughlin from 2005. And they looked at rates of psychotropic use on admission to discharge. And found that 66% of children at discharge were on less medication. And their intervention was the milieu within the residential setting, and then having kind of a structured approach to reviewing medications for these kids. So a structured approach for deprescribing, and they were able to decrease the number of medications from when kids were admitted from 3.1 down to 1.8 average medications. There are 4 other studies that look at residential settings. Most of them are incorporating deprescribing into the prescribing practices and then using that treatment milieu to help support the child, and also implementing some CBT structured therapy to help reduce medications in the residential settings. Terry Lee and his group in Washington have a really cool program out in Washington State where their program only uses antipsychotic medication for patients that are psychotic or have bipolar mania. They don't use antipsychotic medications or mood stabilizers for aggression. Instead, they have the entire staff and milieu staff trained in CBT, DBT model, and they have showed significant decrease in psychotropic use when compared to similar facilities. And you can see that 25% decrease, whereas other facilities, juvenile justice facilities in their catchment were actually increasing the rates of psychotropic medications. So it's a pretty neat model out in Washington State. Inpatient units also are kind of that structured environment and an opportunity to implement deprescribing. This is an article that came out in 2017. And what they were doing was discontinuing or identifying children with ADHD that were on antipsychotic medications and tapering them off those medications in a structured approach within an inpatient setting. So again, why do we need this call for deprescribing pediatrics? It sounds, like a good thing to do, but we really do need this within child psychiatry because of some of the data that's come out over the last decade. We know that the rates of psychotropic medications in pediatrics has just expanded over the last decade, including in very young children. So in preschool age kids, the use of psychotropic medications has increased over the last decade. The use of polypharmacy has doubled since the 1990s. Off-label use of antipsychotic medications is on the rise. The most antipsychotic medication prescriptions in Medicaid for pediatrics are not for psychosis, they're for disruptive behaviors. And with this increased number of psychotropic medications, there's increased concerns for cardiometabolic side effects. And again, there's a lot of this research coming out that continue to kind of raise the red flags in child psychiatry around the overuse and potentially inappropriate use of psychotropic medications that we as child psychiatrists really need to respond to. This kind of red flags around the overuse of medication continually makes it in the New York Times. This is the article on the left was from, I think, a year and a half ago or so, talking about a youth that was prescribed 10 plus medications. And then there's other ones that have come out over the years. Both of the other articles were from 2015. The Mercury News article is a series of articles and videos about youth that are alumni from the foster care system, talking about their personal experience being on psychotropic medications, talking about being over sedate and gaining weight. This article series led to significant oversight in California. California now has some of the most restrictive oversight practices in the country. If you're in California and you want to prescribe any psychotropic medication, even Benadryl, to a child in foster care, you need to go through the court system. So it's like the Rogers process on steroids in California. And they have shown decrease in antipsychotic medications. The question I would have for California, are they doing harm by limiting psychotropic medication so much for their kids in the child welfare system? In the oversight from our federal government, state and local and state government continues. The GAO report from 2011 kind of was the first one that came out, but every year there's a state that gets audited for psychotropic medications. And so this isn't going away. And us as child psychiatrists really need to be there and not let folks that don't understand child and adolescent psychiatry make rules for us around what we can prescribe and what we can't prescribe. Within ACAP, we don't right now have much guidance. So there's 2 clinical updates that talk about discontinuation practices for youth. One is the clinical practice guidelines for depression. The other one is anxiety. And so for depression, we do have some guidance that there should be remission for about 6 to 12 months before trying to taper or discontinue that medication, to be trying to discontinue in a low stress time period. And that for youth that have more severe diseases, they may need a lengthier treatment. And the same similarly for anxiety, there's kind of a time frame that they give to discontinue after 12 months of being on or 12 months of being in remission from the anxiety disorder, discontinue during a low stress period, and then youth with more chronic disorders may need a lengthier treatment. But that's all we have. So SSRI medication, that's about all we have. So this within ACAP as co-chair of the Adoption and Foster Care Committee, many of our members do psychotropic oversight work, consult to child welfare agencies. And so we really wanted to be at the table and develop kind of best practice guidelines for child and adolescent psychiatry. So we have a structured approach to taking kids off of medication. And this led to us developing the clinical update, which has been in the works for about 4 years or so. We did a comprehensive literature review. It should be coming out hopefully by the end of the year. So a lot of what I'm going to talk about next is informed by kind of the clinical update. So now we're going to head into the clinics of FACES kiddo from the foster care clinic. So Emma is a 14-year-old youth in foster care who came into custody last month following concerns for neglect, who presents to that should say a psychiatric appointment following a recent inpatient psychiatric admission. Youth was admitted following a severe aggressive episode at school. Youth had not been going to school though since October, so they got suspended back in October. Mom just kept the youth at home. There was a 51A that was filed for the child not going to school. Youth comes into the child welfare system, goes back to school for the first time, and there's this big outburst. And so Emma ends up boarding in the ED for about 4 weeks or so because of a bed shortage. And she's, acute, and she's required multiple medication restraints while awaiting placement for inpatient level of care. Once on an inpatient level of care, she has about 2 weeks of treatment on the inpatient level of care, diagnosed with ADHD, depression, and PTSD, and discharged on the following medication list: dexmethylphenidate, XR, 15 milligrams in the morning, risperidone, 1 milligram BID, guanfacine, 1 milligram BID, mirtazapine, 7.5 QHS, and then escitalopram, 5 milligrams in the morning. All right, so let's apply best practices in deprescribing to Emma, to this outpatient case. So the 5 steps in deprescribing start, of course, with a comprehensive assessment. The second step has to do with medication reconciliation and assessment of the effectiveness of the medication. Step 4 is incorporating the medication changes into that comprehensive treatment plan. And then step 5 is the implementation, monitoring, management of the medications. So step 1, comprehensive assessment. So within the psychiatric evaluation, we really want the voice of the caregiver and the child. We want to make sure that we're getting information, especially when the youths are in the child welfare system, from multiple sources. We want to incorporate the family of origin when appropriate, talking with our child welfare system, talking with the school and therapists when appropriate. We want to be using structured and standardized screens, so we have data and tools. We want to be incorporating the impact of trauma and adversity, so having that trauma-informed lens on our diagnoses, so that we're not missing trauma symptoms or mislabeling trauma symptoms for another disorder, and then incorporating the impact of culture and race on the current presentation. So for Emma, in her follow-up following discharge, foster parent, she ends up going to a foster home. Foster parents are concerned about the oversedation and weight gain. School reports she's falling asleep in class. At home and at school, they're reporting no outbursts, no aggressive episodes. And youth noted enjoying spending time with our foster sibling. And the youth is currently, of course, on a waiting list, awaiting therapy. So for Emma, what we want to do once we have that comprehensive assessment, we get the information from school, from all of our collateral information. We want to make sure that we're looking at the complete medication list. We want to make sure to obtain that comprehensive medication list, including over-the-counter medications, supplements, and vitamins. So many of our kiddos are on too much melatonin at times. And we want to make sure that our diagnoses are aligning with the medications that the child is on. We want to assess for the effectiveness of the medication through youth voice, of course, but as well as getting that collateral information from the caregivers, the teachers, and other supports that the youth might have. We want to review the past medication trials when available, Incorporating the impact of the environment is so important. If there's active concerns for safety within the environment, that can contribute to some missed symptoms and signs. And we want to make sure that we're not that we're not identifying symptoms as side effects of medication. So the difficulty paying attention in class for Emma, is that her ADHD, or is she oversedate from a side effect of the medication? So here's a list of kind of where to start when identifying a medication that possibly can be reduced or stopped. You want to start with meds that have that don't have a clear indication. So there's not a good indication. So a good one on Emma's list would be the risperidone. There's not a clear indication for the ADHD, depression, or PTSD. We want to also go with the medications that have the least evidence base for symptoms or diagnoses that she's being prescribed. So she's on mirtazapine at a low dose, the SSRI at a low dose. The Lexapro has a better evidence base than the mirtazapine for depression, so why not just optimize that? Ineffective for the symptoms it's treating, or the symptoms have already resolved. Medications that are prescribed outside the guidelines, again, so that would be the risperidone in her case, and insufficient benefit to justify the harms. So with the risperidone, we're worried about that metabolic profile for her. And medications that have risks for future adverse effects. And then medications that are part of prescribing cascades. And a prescribing cascade is when you're misinterpreting or misdiagnosing a side effect as a symptom for another disorder, and so then continue to add medications, and you can get a layering effect. So looking at Emma's medication list, there's concerns for that oversedation and waking. The two medications on here that can cause that real oversedation and waking can be the mirtazapine and the risperidone. And so those might be high on the list to stop. The other thing is to look for drug-drug interactions. And this is a common drug-drug interaction that I see when I'm doing peer-to-peers through Mass Health, the use of guanfacine and mirtazapine together. So the guanfacine has an evidence base for polypharmacy with the stimulant medication. It's an alpha agonist. Mirtazapine is actually impacting the effectiveness of the guanfacine. It's going to block as an alpha 2 antagonist. So this just isn't sophisticated psychopharm. Also, as I mentioned before, the escitalopram would be within kind of the standard practice for adolescent depression, as well as therapy. And is a fairly good choice for polypharmacy. Of note, again, from doing peer-to-peer reviews, fluoxetine is just a hard one to have in polypharmacy medication lists. It has a lot of drug-drug interactions that you have to monitor for. So it's always good to think about being able to switch fluoxetine if you're able to when you have multiple psychotropic medications. All right, so going back to her med list, mirtazapine is kind of high on the list to get rid of, but let's walk through what it looks like to discontinue each of the medications. So step 3 is the actual medication discontinuation, and best practices for discontinuing medication in pediatrics is, of course, go low and go slow. You really want to try to avoid withdrawal symptoms. Children have a higher risk of withdrawal symptoms from psychotropic medications. You want to work with one medication at a time so you know what's working, what's not, and you really want to be able to monitor closely for those withdrawal symptoms, but also for rebound symptoms of the disorder, such as depression or ADHD. So looking at stimulant medication, what does the literature tell us about discontinuing this class of medication? Well, we know that stopping stimulant medication in kids with ADHD can cause a rapid reemergence of symptoms. So you have to be cautious when stopping stimulants for children with real ADHD. The catch is, though, looking at those discontinuation studies, about 70% of the kids will have reemergence of symptoms, but there are those 30% of kids that don't rebound. So it is really important for kids that have ADHD to be applying deprescribing and really kind of checking in about the risks and benefits of continuing the stimulants to try to catch those 30%. We also know that drug holidays can be a way to mitigate some of the adverse effects from the stimulant medication, such as the appetite suppression. And then using stimulant medications with an antipsychotic medication, abrupt discontinuation can cause movement disorders related to the dopamine system. So something to be aware of. All right, what do we know about discontinuing alpha agonists? We know this, if you're going to rapidly stop an alpha agonist medication, there can be rebound tachycardia and hypertension, so we want to do a slow taper. And then autoamoxetine has a longer half-life, so you're not going to see the reemergence of those ADHD symptoms like you will with a stimulant medication until a couple weeks after discontinuation of it. So that's important anticipatory guidance for parents to be, or caregivers to be aware of. All right, so now let's look at what it would be like to stop risperidone or antipsychotic for disruptive behavior. So what do we know about discontinuing antipsychotic medications? So the discontinuation studies that we have for antipsychotic medications are mixed. So there's a group of studies that note stopping the antipsychotic medication can increase aggression, but there's also other studies that show no difference, that some kids didn't have reemergence in the disruptive behaviors. We also know, though, that if you're able to reduce or stop the antipsychotic medication, you can have a reduction in weight gain, and that metabolic side effect, and the prolactin will also normalize if there is elevation in prolactin. So it's really important to try to use the lowest effective dose. And again, there's the caution when you have a stimulant and an antipsychotic medication, it can cause muscle movements or dyskinesias if they abruptly stop. The other important thing to note is the importance of therapeutic supports for antipsychotic medications that are being used for disruptive behaviors. Using particularly parental support, so parent training interventions can more easily be able to decrease the antipsychotic dose or stop the antipsychotic completely. And the Umass study was actually done with kids in autism. The other two were for disruptive behaviors. All right, so in general, what do we know about stopping medications for disruptive behaviors? Psychosocial interventions are really important, especially that parent component. So not just the child, but really being able to focus on the parent. Using evidence-based treatments. Actually, if the child's been on the antipsychotic medication for a longer period of time, it's easier to get a successful taper. So that was a year. And then slow antipsychotic tapers over weeks instead of kind of abrupt short tapers can lead to less rebound of the disruptive behaviors. All right, so now we're going to move to SSRIs. What do we know about discontinuing SSRI medications? So a review of the literature notes, of course, that what we need to focus on or be concerned about is SSRI withdrawal syndrome. This is a flu-like symptoms that can cause lightheadedness, dizziness, really doesn't feel good for the patient. And it's important to know that there's specific risk factors for kids. So if the kid is a younger age or smaller, they have increased risk factors for SSRI withdrawal. The length of the taper can impact the risk for withdrawal, how the child metabolizes the medication, how long the child's been on the medication. So if they've been on the medication longer, then they're more at risk for withdrawal symptoms. If the medication has a shorter half-life, such as paroxetine, then they're more at risk for withdrawal symptoms when you're tapering it off. In terms of SSRI discontinuation studies, there's 2 randomized controls, both flag for the risk for relapse for depressive symptoms. The first one looked at fluoxetine and had a 6 months discontinuation phase, and almost 70% of the placebo group had some worsening rebound symptoms and some relapse in depression. 100% in the smaller study that had 22 had rebound symptoms. That one was over a year. So discontinuing SSRI medications in depression, there is that risk for relapse that needs to be addressed, which is where our clinical guidelines within ACAP suggest a trial after 6 to 12 months of remission from depressive symptoms. But if there are more chronic or severe 2 or more depressive episodes, they may need a longer period of treatment. So looking at discontinuation factors for SSRIs, for anxiety, again, for anxiety disorders, we're looking at a 12-month period of remission and doing this in a slow taper that's stress-free. Additional factors is the use of CBT can be helpful in being able to taper off the SSRI medication. If the patient's had a good response to the medication, they can have a better chance to be able to taper off. Less severe anxiety at baseline, younger age, male gender, no co-occurring conditions, and then fewer negative life events or ACEs. All right, so we went through kind of what it looks like to discontinue the psychotropic medications. Step 4 is incorporating these medication changes into the treatment plan. So for this, we really want to hear the patient and family voice. We want them to understand the risks and benefits of stopping the medication. We want there to be shared decision-making. So talking with the child about which medications, they feel like they want to stop. Making sure that, especially for kids in the child welfare system, that other folks are involved and aware of the choice to stop medication, incorporating the voice of the social worker or congregate care staff if the child's in a residential placement. Psychosocial interventions are, of course, really important to ensure to prevent relapse in symptoms, and then also communication with the school and making sure that the child has appropriate school supports as well is important to think about with the treatment plan. So for Emma, she actually felt as though the risperidone had been helpful for her aggression and was really hesitant to want to discontinue it at this time, but yeah, it was open to stopping the mirtazapine. What we're talking about when we're thinking about this comprehensive kind of treatment plan, we really want to take that systems of care approach for our kids. The systems of care philosophy started back in the 80s, and with the goal to keep children in a less restrictive environment. So to keep children at home, keep them out of residential and congregate care settings, and incorporating all of the systems that are involved with the child in a coordinated response that's individualized, culturally competent, family-driven, youth-guided, and based in systems of care philosophy. The key planning measure with wraparound, of course, is wraparound service planning that ensures that there's no fragmentation and that care is coordinated. So thinking about for the caregiver, which interventions to put in place. There can be a family partner or peer support model. There can also be access to respite as a therapeutic support to consider. For the child, there may be in-home based therapeutic supports, therapeutic mentor, or after-school programming that might help wrap around and build up the family. So in looking at Emma, the foster home was really stable, really positive. She had a good relationship with the caregiver and siblings. The caregiver was predictably available, but what they would benefit from would be that peer support. So connecting them, we have a family partner model that faces our trauma coach, so that peer support for the foster parent to help build up that relationship would be a key piece to Emma's treatment plan. Emma didn't have an IEP, so for her, it was advocating for an IEP for the social emotional piece. She's pretty intelligent kiddo, but just pulling in that IEP for the social emotional needs and assessing for those ADHD symptoms, any breakthrough in the ADHD symptoms with the school as well. For therapy for Emma to target her PTSD and depression, individualized trauma-based therapy is key. Thinking about a therapeutic mentor as well for Emma, or after-school activities also would be key for her. Continued coordination with the child welfare system is really important. The child welfare system has resources that they can implement to help stabilize family and kids that are in foster care. This often takes some advocacy, but as child psychiatrists, we sit in a place where we can really advocate and really put in services for our kids. So step 5 in deprescribing is a really important step. So this is once you decide what to stop, it's implementing the plan to go ahead and stop the medication, but then monitoring and managing the symptoms. So oftentimes when you're tapering or stopping a medication, there actually needs to be more frequent appointments. You want to make sure that there's no relapse in symptoms, possibly using monitoring scales to make sure that you're identifying any relapse in symptoms. You want to make sure to provide anticipatory guidance to the caregivers and the child around what withdrawal symptoms look like and what to do. Sometimes it can be difficult to tease out what's a withdrawal symptom and what's a relapse symptom, especially when you're thinking about like irritability. Is that increased irritability coming from the decrease in their risperidone, or is that a withdrawal symptom for pediatrics? And then feedback from the youth, caregiver, and collaterals. So making sure that you're getting the conversation from the school, from the therapist, making sure that you're getting input from multiple sources is really important. And then monitoring for any clinical worsening of symptoms, especially with depression, thinking about screening for suicidal ideation, self-injurious behaviors, homicidal ideations, and the need to monitor for crisis or hospitalization if that occurs, and making sure that parents and family have a plan around the crisis and hospitalization. And yeah, I think I got all those points. So for Emma, over the course of a couple months, we were able to slowly reduce the risperidone medication and try to optimize the escitalopram to help treat her depression. But again, Emma really felt as though the risperidone was helpful for her anger outbursts and aggression, and she preferred to continue on this medication. And that's where the monitoring piece is so important. So making sure that each of the medications is being monitored for, especially with any drug-drug interactions, making sure that there's frequent appointments, making sure that there's in-person appointments when possible, especially for kids in the child welfare system, and getting vital signs and lab work when indicated is really important. In the work I do with DCF and reviewing our kids in state custody, this piece, the lab work and monitoring plan, is something that we're really pressing to improve. There's room to grow with the monitoring for antipsychotic medications. So after a year following Emma, she was able to slowly taper off the antipsychotic medication, continued on the medications for her ADHD and depression. The key piece with Emma's story really was that foster parent relationship, as well as the relationship with her foster siblings, having that stable caregiver setting really let Emma kind of do well, and made it easier for me to be able to deprescribe and get her on less polypharmacy. So next steps for deprescribing, when we did the initial literature review going back from 1980 to current present, there's only about 170 articles on deprescribing and pediatric psychiatry. So there's really a need for more research in this field to help better practice tools and protocols. We also need advocacy for this work takes a lot of time, so we really do need some advocacy around reimbursement to do this work. Continued education around deprescribing, so making sure that our medical students and residents and fellows are learning this and thinking about it, and then helping to develop practical tools that are easy to use in the clinic around deprescribing for prescribers. I have a lot of references, but that's it. So thank you.
That was very, very, very good. One thing you didn't mention, because the study's are really in adults, but something for child psychiatrists to be concerned about, I think, is that there have been studies now that show that there are deleterious structural effects on the brain, loss of brain matter in adults who go on antipsychotics. Now, psychosis does the same thing. So psychosis is bad. And if you are suffering from a psychotic disorder, you should take an antipsychotic. But it raises the question of whether, and I'll just speak for adults, whether you should take an antipsychotic if you're not psychotic, if you're just suffering from major depression or an anxiety disorder, and that we adult psychiatrists should refrain from I think we should refrain from prescribing antipsychotics to people who are not psychotic. But I worry about it even more in the developing brain. I mean, these are people we studied, who are well beyond the age of 30, many over the age of 60. So you should add, I think you should add that to your list, besides the metabolic problems. Other questions? Comments? Pass that back to.
Hi, Johnny. Well, if you had a wish list of 1 or 2 things with these kids that the whole state would start doing tomorrow, what med change would that be? Like, what do you go, I can't believe they're still doing this?
It wouldn't be a med change. I think it would be a therapeutic intervention. So Terry Lee's done a lot of work on MST psychiatry, which is a really expensive model. So there's evidence base in kind of juvenile justice population, but also in child welfare population. But that's for kind of high needs kids, being able to put in a real therapeutic team that has high quality therapeutic services to keep these kids at home with consult, and then the team has ongoing consultation back to the psychiatrist. It's a great model, but it's super expensive. But that would be kind of the intervention that I'd kind of like our state to consider, especially for the kids, John, that you take care of on the CCUs. That would be a great kind of step way kind of down for some of the kiddos. For me, where I sit at DCF, I see over and over again the overuse of antipsychotic medications, as well as mood stabilizers. And the catch is that they work in the moment. The trick is that then our kids stay on them too long. And so that's where I think really talking about deprescribing is really important. Once kids are started on antipsychotic medications, or kids in the child welfare system, they stay on them. Part of it is the fragmentation, going from place to place, seeing multiple providers, nobody knowing kind of what works and what doesn't work. But right now, antipsychotics is what I review a lot for DCF.
So I have a political question.
Okay.
We in the pediatric realm have taken on this lingo of deprescribing, and yet I've been in multiple settings, particularly with psychiatry colleagues, who say, don't use that term. You can't use that term. And in fact, when we tried to publish a position paper between the American Academy and ACAP, we were told you have to take that term completely out of the document. So how do you want me to talk about it? What are we supposed to say? And who is leading that and why?
So that's so thanks, Heather. So when we first started this effort at ACAP, probably 6 years ago now, we couldn't use the term deprescribing, which is where our clinical update has appropriate use of psychotropic medications. The culture, though, at ACAP has shifted significantly in the 6 years that we've been advocating for this clinical update. So now, when you read our clinical update, there's deprescribing throughout it. So that's shifted. I think my understanding is part of the fear was, what we do as child psychiatrists is medications. So they're like, Dr. Morgan, are you advocating that we don't prescribe medications? Like that's kind of why people come to us is for medications. So they were worried about kind of the negative lens that might have on using psychotropic medications in kids if we're out there saying that there's all these concerns for inappropriate prescribing. Our point within our committee was we need to be at the table because every state has oversight now. And so you're having people that aren't in pediatric mental health kind of making up the rules for you potentially. And so we really want child psychiatry to be at the table. And, we are that we can use that term now freely. That's shifted within ACAP. thankfully. So.
I have a question from online. When kids with trauma are diagnosed with ADHD and later it's realized that the ADHD is secondary to the trauma, the meds hopefully go away, but does the diagnosis?
Yeah, I take that diagnosis away all the time in the FACES clinic. So ADHD and trauma is probably the most common question that I get in the foster care clinic, the FACES MCPAP clinic that I have. And I take it away. I think if there is concern, getting a neuropsychological evaluation can be really helpful to try to tease out, is this trauma or is this ADHD? So relying on our colleagues in that discipline. But in the moment when you see a child that's been traumatized, it's really hard to say whether or not it's ADHD or trauma. The school's reports are all like 3s on the Vanderbilt, and then the caregivers' reports are all 3s like throughout. And so in the moment, it's really hard, but that's where it's really important to have time with these kids. And that's actually where we have our FACES MCPAP pilot, because it's a bridging service and we're able to follow these kids over time, which is, I think, really important in terms of teasing out trauma diagnoses as well as other comorbid diagnoses. I'm always trying to get in touch with family of origin to get that developmental history. So if you're seeing like a 9-year-old, being able to talk with the family of origin about the development, preschool years, kindergarten years, to try to help tease out, again, that diagnosis of trauma or ADHD. Sometimes it's both, and sometimes it's just hard to tease out.
So Wynne, I know a key message is that deprescribing is important, but you also sort of on the side shared how much the psychosocial interventions are critical to make that a successful process. And we all know that there are challenges with wait lists and getting people into appropriate care, but also that you have been able to sort of use other creative approaches within the clinic to still get some of that done, even though there are those challenges. If you could talk a little bit, even though it's not about medications, but what are those pieces of the FACES MCPAP and how you do that work and how that is helpful?
Yeah, so I think the FACES MCPAP clinic has really been successful because we're interdisciplinary. I have my colleagues over here, but being able to learn from people in other disciplines, so learning from the pediatrician colleagues, but also learning from our trauma coaches, trauma educators, educational navigator, all have lived experience having raised children in the child welfare system or in foster care or adopted these kids. So that interdisciplinary piece has been so valuable in terms of how I provide kind of trauma-informed psychiatry to the patients that come in, using a lot of the tools from the resource parent curriculum, which is a NCTSN curriculum, has really great kind of strategies and models and conversations that you can have with the foster parent or caregiver. A lot of the work that we do is around supporting the child, but it's also supporting the foster parent. The foster parents go into this work because they want to do good. Often they have the ability to take on another child, but they don't often have a lot of that support or education about what it means to care for a child that has experienced chronic trauma. And so that's where I think having those conversations with the foster parent, supporting the foster parent is really, really important. So is that what you were thinking, Yael? Okay, yeah.
I have another question online. So this questioner says that at some level, they can understand antipsychotics being treated differently than other medications, but that there are plenty of other medications with complex risk-benefit profiles. Does it make sense to have special rules, legal oversight for antipsychotics alone?
So within the state of, so I work with kids in the child welfare system. Within the state of Massachusetts, there are kind of two oversight systems. One, we have PBHMI, which is the Pediatric Behavioral Health Medication Initiative, which is for all kids on Mass Health. And that's for all psychotropic medications. There's age restrictions, polypharmacy restrictions, intra-polypharmacy restrictions. So if you're using 2 antipsychotic medications. And then if you have a child in the child welfare system, there's also the Rogers process. So which is a court-appointed process. So I don't think that the court should be able to make medical decisions for our care. And that's part of the work that I'm trying to do within DCF, is have this AMP project that's able to do a medical review for our kids in state custody. So it's not left for judges and attorneys to prescribe. My work at PBHMI, doing peer-to-peers and talking with people, I'm seeing some pretty concerning cases. And I think the work that we do is valuable in terms of our doc-to-doc intervention. I do worry, though, about the burden of the PA process on outpatient providers. I fill out a lot of the PAs at the FACES clinic because all of our kids are on Mass Health. But I do worry about that balance, and something that we at PBHMI are actively thinking about.
Hi, Dr. Morgan. I'm not sure how many students, residents, or fellows are listening in or in the room here, but I just wanted to state how much you took something that you are passionate about, from medical school to residency to fellowship, and really took that passion to then become a state lead for DCF and now a national thought leader. I mean, I think you were very humble about it, but you are one of the reasons why there was a little bit of destigmatization of the word deprescribing at ACAP. So I just wanted to commend you, and hopefully that can be an inspirational story for other learners who are listening to you speak today.
Yeah.
Well, that's a perfect way to end. Thank you very much.